So, this session is about the part 3 of recall questions of 2023 in NEET-SS MCS surgical group. And this third part, let us see what are the questions asked and where are the reference taken from. CA breast in pregnant female different from normal female. Which of the following is wrong? No need for mammography in pregnant female. Worse prognosis as compared to non-pregnant female. Neoadjuvant treatment can be given in second and third trimester. Dilated ducts can be confused with lobular lesions. The right answer is, see, the treatment and prognosis all are the same as with non-pregnant. Okay, so there is no difference at all. So, only the indication for chemotherapy and radiotherapy is very important, should be avoided in first trimester. The only concept that you should know and can be given in second and third trimester. Or else nothing else is there, and it is given in Bailey 28th edition, page number 942. Okay, so whatever we have discussed, and surgery is also preferred and performed in any trimester. Surgery can be performed in any trimester. Only radiotherapy and chemotherapy should be avoided in first trimester. A young girl whose fingers change color from white to blue and to red in exposure of cold, she was evaluated for rheumatological illness and her screening markers came negative. How will you explain prognosis to her? So, this is a typical feature of Raynaud's, correct? Yes, it happens to the exposure to the cold. Okay, it happens white, blue, red. So, it is very typically the option A. So, Raynaud disease, it will be having a waxing and waning of the course depending on the temperature the fingers are exposed. Because the tendency is there, so it will happen. So, Raynaud's disease idiopathic condition occurs in young women, okay, affected in hands more than the feet, and there is an abnormal sensitivity to arterial response to cold, and this vessel constrict and the digits turn white and become incapable of fine movements, and the capillary which dilate and fill slowly following the deoxygenated blood, resulting in the digits of swollen and dusky, and as the attack passes off, the arterioles relax and oxygenated blood returns. So, when the deoxygenated blood flows, it becomes blue, and as the attack passes off, the arterioles relax and oxygenated blood returns to the dilated capillaries and the digits becomes red. So, it becomes red. So, white, blue and red. This condition is recognized by the characteristic sequence of blanching, dusky cyanosis and red engorgement, often accompanied by pain. Superficial necrosis is very uncommon. The condition must be distinguished from Raynaud syndrome, which has similar features of Raynaud. See, Raynaud syndrome, they said. It is there elsewhere. And the treatment of Raynaud's disease consists of protection from cold. It is not always surgery. And avoidance of pulp and nail from infection. Calcium antagonists such as nifedipine may also have a role to play, and electrically heated gloves can be useful in winter. Sympathectomy has also been used in past. It is either ineffective or its effects are short-lived. So, now go back to the options there. It may worsen, leading to amputation of fingers. Very, very rarely happens. And it is curable. No, it is not curable. It is controllable. Surgery is not a definitive treatment. Protection is most definitive treatment. Which graft has been best patency rate for 10 years? So, it is the arterial graft which has the highest patency. Left internal mammary artery or right internal mammary artery. Okay. Lima. If more grafts are required, Rima. If both the grafts are required, it is called Bima. Left internal mammary artery, right internal mammary artery. Bima is bilateral internal mammary artery, and we say Lima, Rima, Y. We say Lima, Rima, Y, and it is concept is total arterial revascularization is the best concept today. Patency and efficacy of the graft is very high for the total arterial revascularization. So, that is what is been mentioned in 20th edition of Bailey in page number 950. See that left internal mammary artery or internal thoracic artery become the conduit of choice for LAD grafting. The evidence from the mid-1980s to present day suggests that 10-year patency rate is more than 95% with lower reoperation rates. What more you want? So, word to word, line to line. Which of the following is true about keloid? See, we have two things, keloid and hypertrophic scar. We know keloid goes outside of the boundary of the wound and hypertrophic scar grows within the boundary of the wound. Both have abnormal collagens and more collagens. So, what will be your best answer for this question? So, the right answer for this question should be more collagen, less vascularity. More collagen, less vascularity. This is the reason why is very, very difficult to even put in a needle. So, you want to put a steroid, okay, intralesional steroid, intrakeloidal triamcinolone. It's very difficult to inject because it is very tight and it will not bleed much, but it is very, very hard. So, aberration of normal wound healing has such as a prolonged. So, page number 28 in 20th edition says prolonged inflammation results in excessive scar tissue. For example, hypertrophic or keloid scars. The abnormal scar contains excessive collagen, which is arranged in disorganized pattern in keloid as opposed to parallel pattern in hypertrophic scars. Only one difference. So, disorganized in keloid and parallel in hypertrophic scar. So, answer is more collagen, less vascular. Which is correct about split skin grafting with reference to full thickness grafting? Split skin and full thickness, partial and full, other words. See, whenever we say, see, what is the process of grafting? The process of grafting is to, let us take a split skin graft. Split skin graft are taken from the area of more surface areas where the skin is available, especially the thighs and the anterior or posterior or middle aspect of thigh or anterolateral aspect of thigh, where the graft is taken with a Humbee's knife. I mean, now mechanized machines are available to harvest. Now, the Humbee's knife is a time-honored traditional method of taking up. And once you take it, you will take it up and put it in a bowl of saline. Once you put it in a bowl of saline, the graft will shrink and will contract. This contraction is called primary contraction. I am talking about SSG. Now, what will you do? You keep the graft over a wooden log. Okay, when you go to a burns unit, you keep it in a wooden log and you will try to slit the graft. This is called meshing. What is it called? Meshing. And this is done to increase the surface area of the graft. If it is only 10 square centimeter, you can increase it to 15, double it. By this way, it will improve the stretch. And this is called meshing. Meshing. Then what you do? You put it on a, suppose the ankle area, you want to put this graft. You put it on the graft in the ankle area. This graft you put it. The donor site. So, the recipient from the thigh you have removed. This is the donor site and this is the recipient site. For the first 48 hours, it will survive by plasma imbibition. After 48 hours to 5 days, plasma inoculation, plasma inoculation. So, first plasma imbibition, then plasma inoculation, and after 5 days, neovascularization. The graft will take and heal once it is taken. Suppose if a streptococci is there in the bed, it will 100% get rejected. Suppose there are few unfavorable features in the recipient side, it will get rejected, but if it is taken up, it survives. It will also heal by contraction, and that is called secondary contraction. So, primary contraction is the time where when you harvest the graft, secondary contraction happens in the recipient side. Understood? So, with respect to the SSG, the primary contraction will be less, and the split skin graft in the donor side, it always heals by contraction, it is cosmetically poor. So, the secondary contraction is more. In full thickness graft, it is reverse. Full thickness graft, you take it from a supratemporal region, postauricular region, in the axilla or in the groin. Those areas where excessive skin is there, you can take it, and it is put for cosmetically more important area. The minute you harvest the graft, you remove the epidermis, dermis and subcutaneous tissue with elasticity. The graft will fold like this. So, this is the primary contraction. It will be more. Once you put it on the recipient site, it heals superiorly, heals with less contraction. Cosmetically superior, that is the reason why you use full thickness graft. Yes, to reconstruction anything in the face, it heals with less contraction. This is called secondary contraction. Secondary contraction will be less. Primary contraction will be more in full thickness graft. This is what it means. So, this answer is A. Less primary contraction, more secondary contraction and less metabolic demand is for split thickness grafting. Is it okay? So, this is the right answer. Same what I have explained, it is available in Bailey and Love 28th edition, page number 1975. Split skin grafting is a simple method of tissue transfer. The name is derived from these grafts and harvested by cutting through the dermis at various levels. Thin SSG harvested through superficial levels of dermis and thick grafts are harvested through deeper level of dermis and include large amount of dermal tissue. The important characteristic of SSG is to determine the thickness of dermis present in the graft. Thin grafts undergo less primary contraction and harvest they contain fewer elements of dermal extracellular matrix such as elastic fibers. On the other hand, thin grafts allow the wound to undergo a greater amount of contraction resulting in as a secondary contraction of the graft. There will be more. Understood? On the recipient side. So, the right answer is option A. Damage control surgery includes all except. The triad of damage control surgery is there. This is a very classical phenomenon and the right answer is definitely option D, because when you see Bailey and Love 20th edition page number 358, damage control surgery versus early total care. See, the concept of damage control surgery is developed because of severely traumatized patient with impaired physiology have a poor outcomes after a lengthy and complex surgical reconstructive procedure performed shortly after their trauma. Prolonged procedures result in additional trauma and further immune and physiological derangements. The triad of death, that is number 1, a cycle of acidosis, number 2, coagulopathy, number 3, hypothermia may develop result in multi-organ failure and death. So, all 3 are there: coagulopathy, acidosis, hypothermia. 22-year-old boy with a penetrating injury to the left lower chest comes to the ER, suspected of cardiac tamponade. Systolic blood pressure is 70 mm of mercury. Ideal management. The very same question is there in the app, in the test, and also discussion is there. Very same question. There is no change in the question. And I also have told you pericardiocentesis should not be done. So, you have to go for immediate surgery. Either be an anterolateral thoracotomy or mid-distal sternotomy. Okay, the very similar tabular column was also discussed, is available in Bailey, 20th edition, page number 375. See, the presentation is similar to the tension pneumothorax, deteriorating with cyanosis, tachycardia and agitation. E-fast is diagnostic and may also detect a free fluid in the abdomen or pericardium. There is no role for pericardiocentesis in traumatic cardiac tamponade. No role. Left anterolateral thoracotomy or sternotomy should be performed to evacuate the hematoma and repair of myocardium. Finished. Chapter closed. When you see a penetrating injury, you have to open up. That's what Bailey says, that's what the answer is also. At least the BP is holding to 70. He is not exaggerated. It's very important. So, according to ATLS, the site of needle insertion in tension pneumothorax in adults. Let's read the explanation. Bailey 20th edition, page number 374. Treatment consists of immediate decompression. This was historically thought with a rapid insertion of large bore cannula in the second intercostal space in the midclavicular line in the affected side, followed by insertion of chest tube through the fifth intercostal space in the midaxillary line. Let us wait. You just need to tell me whether it is a needle or the tube. I mean, do you remember it's a tube insertion or a needle insertion? If it is a needle insertion, the answer should go for option A. See, triangle of safety is formed anteriorly by the posterior border of pectoralis major, posteriorly by anterior border of latissimus dorsi, and inferiorly by the fifth rib. So, this is pec major, this is LD. See, this will cut across mid-axillary line, but anywhere in this region, in this triangle, within this triangle you can put. Either you just come here, it will be an anterior axillary line, or right in the middle will be the mid-axillary line. So, this is the ideal place to put a tube, because this is called triangle of safety. This is called triangle of safety. And because putting in this triangle, it is safe for internal structure not to be injured, major structures. This is the whole idea. So, it is a needle, it is a second intercostal space, midclavicular line, very clear. or chest tube insertion, fifth intercostal space in anterior axillary line. It is given in anterior axillary line, up to mid axillary line can also be planned. It is very clearly given here. However, the current teaching advocates undertaking of decompression in the triangle of safety, defined posteriorly by latissimus dorsi, anteriorly by lateral border of pectoralis major, inferiorly line perpendicular to the nipple, going back and just anterior to the mid-axillary line, or in extremis of finger of thoracostomy at the same location. Okay, fine. Patient presents with swelling which moves in perpendicular direction to the mesentery. Intraoperatively, surgeon finds a thick wall cyst arising from the mesentery. What is the ideal management? So, it is a mesenteric cyst which moves perpendicular to the line of attachment of mesentery. Fluid drill can be present, which is a large cyst, and can be a band of resonance also. And because it is going to be a thick wall cyst, it is called an enterogenous cyst. Enterogenous cyst. See, what happens is, if this is the small intestine and if this is the mesentery, and this enterogenous cyst would be something like this. It is a type of duplication cyst. Okay, where it would have been duplicated from the adjacent ileum. Ileum is one of the most common site. But what happens is the blood supply to that part of the intestine from where it is duplicated and to the cyst remains the same. So, what you should do is a thick wall cyst and enterogenous cyst you should excise, no doubt. You should excise the cyst and also to resect that part of the intestine from where it shares a common blood supply. So, resection and anastomose should also happen. So, resection and anastomose of the adjacent intestine along with the resection and excision of the enterogenous cyst. The most common type of mesenteric cyst is a chylolymphatic cyst. The most common type of mesenteric cyst is chylolymphatic. So, the muscle in the wall of the enteric duplication cyst, bowel within which contact with the common blood supply, consequently removal of the cyst always entitles the resection of related portion of the intestine. So, type of enterogenous cyst. See that enterogenous cyst. Where is it given? Bailey 28th edition, page number 1101. What is jettison excess baggage in cancer? The answer is loss of normal cellular function. See, page number 141, 20th edition of Bailey, jettison excess baggage, same word. Cancer cells are geared up to excessive and remorseless proliferation. They do not need to develop or retain those specialized functions that make them good cellular citizens. So, this is what it means. So, go back to the question. Loss of normal cellular function. They can therefore afford to repress or permanently lose their genes that control such functions. So, they become linear and meaner. This may bring some short-term advantages. The long-term disadvantage is that what is today superfluous may tomorrow be essential. This can leave the cancer cells vulnerable to external stressors and may in part explain why some cancer treatment works. Okay. Which of the following is true about cardiac transplant? You remember we discussed about the standard transplant. Standard is biatrial. Yes, biatrial. LA to LA, the sequence. Left atrium to left atrium. PA, aorta and RA. RA to RA if it is standard, or SVC to SVC or IVC to IVC if it is bicaval. So, standard is one type, it is biatrial, LA to LA, RA to RA, and rest of all anastomosed in the sequence PA, aorta, and in case it is going to be bicaval, the same procedure followed, and instead of RA to RA, you do SVC to SVC and IVC to IVC. Understood? So, this is about heart transplant. So, the right answer is option C. Antibody mediated rejection is donor antibody specific. And 20th edition of Bailey, page number 1641. Antibody mediated rejection is seen in 10 to 20% of patients and a mortality rate of 80%. Donor antigen recipient antibody form an antigen antibody membrane attack complex that lead to endothelial injury. The diagnosis of antibody mediated rejection confirmed with the presence of circulating donor specific antibodies DSA with evidence of complement activation, and this is treated with intravenous immunoglobulins, plasmapheresis, anti-lymphocyte antibodies and high dose of steroids. Which of the following HLA has highest association of rejection? The right answer for this is HLA-DR. See, I will tell you the level of mismatch between HLA molecules determine the strength of immune response. Every individual has 2 copies of each HLA gene and each of the locus is A, B or DR. It is possible to have 0, 1 or 2 mismatch genes. As the number of mismatches increases, so does the chances of immune recognition rejection. The best matched grafts are described in having a mismatch of 0, 0, 0 for all 3 and no mismatched at A, B or DR respectively. A completely mismatched graft will be annotated with 2, 2, 2, 2. That means 100% rejection can happen. The effects of different HLA antigens are not uniform. DR mismatches have more powerful effect than B mismatches or A mismatches have least importance. Very clearly said. See how beautiful this book is. Highest association of rejection, HLA-DR, page number 1598. Is it okay? Which of the following feature helped differentiate Crohn's from ulcerative colitis? So, very simple straightforward question actually. Skip lesion seen in Crohn's. Granuloma, non-Kijerian granuloma, Crohn's. Perianal complication common in ulcerative colitis, no, it is common in Crohn's. Transmural involvement is seen in Crohn's? Yes, that is the right answer. Because transmural involvement is in Crohn's. I will just do it. Skip lesion associated to Crohn's. Non-Kijerian granuloma, Crohn's. Perianal complication are more common in Crohn's. So, the right answer here is transmural involvement is in Crohn's. That is correct. Whereas mucosal involvement is in ulcerative colitis. So, again it is very clearly given in a tabular column in Bailey, page number 1321. Okay. So, macroscopic and microscopic. The layers that are involved which are pertinent to the question. Full thickness transmural for Crohn's. Mucosal, submucosal ulcerative colitis. Perianal disease and fistula formation, Crohn's. Granuloma, Crohn's. Ulcerative colitis, cryptopsis, they will ask you. This is a very, very important MCQ. Cryptopsis. So, Rubin flap is based on. This is a very important repeat question. Asked many times previously. This exam also asked. So, you will definitely be able to answer. Okay. Deep circumflex celiac. Parotid tumor with squamous cell carcinoma not involving the facial nerve. Treatment is. See, very rare tumor. The most common tumor is mucoepidermal carcinoma. And they will classically ask you which involves the perineural spread, facial nerve, adenoid cystic. Correct? Which has best prognosis of malignant salivary gland tumor is acidic cell cancer. Here, squamous is very, very rare. Usually involves facial, but in the question it says no facial. Anyway, the right answer should be radical prostatectomy. Treatment of a condition given in the image below. Very, very clearly said the picture showing like an annular pancreas. If it is going to be annular pancreas, surgery is a treatment of choice. It will see it is a differential diagnosis for duodenal atresia, where you see a double bubble sign. Double bubble sign will be seen here and also in duodenal atresia. The right answer for this question should be duodenostomy. Very simple and straightforward question. See here annular pancreas, 20th edition Bailey, 1267. Result from failure of complete rotation of ventral pancreatic bud during the development, so that the ring of pancreatic tissue surrounds the second or third part of the duodenum. It is most often seen in association with congenital duodenal stenosis or atresia, therefore more prevalent in children with Down syndrome. The duodenal obstruction typically causes vomiting in neonate. The usual treatment is bypass, duodenostomy. Duodenostomy. Patient with ulcerative colitis with more than 4 bloody stools with fever and dysplasia, what will be the management? So, if it is more frequent stools associated with bleeding, then obviously you have to go for surgery. And Bailey very clearly says in 1323 page number 20th edition, yes, indication for surgery in ulcerative colitis is there, severe fulminant disease, failing to respond to medical therapy, chronic disease with anemia, frequent stools, urgency and tenesmus. Okay, this is there, and steroid dependent disease, intolerance or side effects to medical therapy, growth retardation, neoplastic change, associated sclerosing cholangitis, extraintestinal manifestation. All this and severe hemorrhage, all these are causes. So, the right answer expected out of this is surgery. on exploration of inguinal undescended testis, which of the following is true? Very, very good question. See, testis is an abdominal organ. That's the reason why it derives the blood supply from the aorta. Yes, by third month, it is either ova or testis after differentiation based on the hormone. It either differentiates into the testis or the ova. If it is going to be the testis, it will start descent. See, from the abdomen up to the deep ring. So, from the abdomen, okay, so this is the aorta, let us suppose. So, if it is 3 months and to the deep ring, it comes to 7th month. And in the canal, 8th month in the canal. Okay. You can't say it's a canal, but it's a transit across the deep ring because there is no canal in, within first year of child. So, you just remember outside the deep ring, it's 8th month. And then you call this as a superficial inguinal pouch. Superficial inguinal pouch, that is about 9th month. And the descent to the scrotum at birth. So, this is the architecture, correct? This is the chronology. Human chorionic gonadotrophin and the gubernaculum of the testis, which aids in the pull and increase intra-abdominal pressure and growth of the anter-abdominal wall, pushes the testis down into the scrotum, correct? So, it will carry a fold of peritoneum along with that. And once after the descent, the peritoneum will totally can obliterate. Yes, the part of peritoneum is called processus vaginalis, which surrounds around the testis. Those which is around the testis alone remains, rest all gets atrophied. If it is present, then becomes hydrocele, congenital hydrocele. There are various types of hydrocele. Depending on the presence of processus vaginalis other than the testis, then in full continuity, it is a complete congenital hydrocele. And there are various types of hydrocele, hydrocele of the cord, infantile hydrocele. A lot of hydroceles are there that you know about it. But among this, what is the question to be answered? Answer is processus vaginalis may be present. Understood? See, the treatment, the question that is asked related to this is the treatment of congenital hydrocele, congenital hernia is the same. The answer is herniotomy. Understand that. The treatment of congenital hydrocele, congenital hernia, the treatment is only herniotomy. You don't do a raphe because there is no inguinal canal, because superficial ring and the deep ring are superimposed. The reason why I was very careful in saying that the canal, you cannot say it because there is no canal. Yes, it will be superimposed. Understood? Okay, the same what we discussed is there in the explanation. You can read through, it will be loaded in the app. The clinical feature of SAH, the true factors. So, these are the various options which are given. The right answer to this is middle cerebral artery is more commonly affected than anterocerebral artery, as taken from Bailey, 20th edition, page number 709. Middle cerebral artery, where you see the number is 38% and anterior communicating anterocerebral is only 36%. So, you need to take this as an answer. Which of the following is true about Lou-Ferrigno syndrome? See, this Lou-Ferrigno syndrome is common and it's a very simple basic question. The right answer is associated with soft tissue sarcoma, adrenal cortical carcinoma and brain tumors. Okay. So, this is a very, very simple and straightforward question. And this is in Bailey 20th edition, page number 202, general surgery. See, Lou-Ferrigno syndrome, sarcoma, leukemia, osteosarcoma, brain tumors, adrenocortical carcinomas, P53. So, out of this 20 questions we have discussed exclusively from Bailey 20th edition. And previously we discussed almost 15 to 16 questions, correct? Part 2. Not a component of SOFA. This is again from Bailey also and available in any other book also. It's a very common question. So, not a component. What is not a component? Total lymphocyte count is not a component. And where you have the system, what are the parameters included? Respiratory system, PaO to FaO to ratio, coagulation parameters, liver bilirubin levels, cardiovascular, about mean arterial pressure, and CNS and GCS score, renal, creatinine and urine output. Total lymphocyte count is not given. 20th edition of Subsistent and page number 63. A male patient with a history of fall, following which he undergoes an ICT insertion for pneumothorax. Patient has an expanding subcutaneous emphysema over neck and thorax. What is the next step? See, he had a pneumothorax, ICD was pushed in. Now, still he is developing subcutaneous emphysema, means still the leak is there, persistent leak is there. Where is the persistent leak? Persistent leak is only in trachea or nasopharyngeal injury, it will keep on building up. So, the answer you should rule out tracheal and nasopharyngeal injury. Okay, simple and straightforward answer. Suspicion of esophageal perforation with symptoms of epigastric or chest pain or neck or throat pain or dysphagia. Physical examination will include crepitus on the chest or the neck or the face or neck swelling or epigastric tenderness or nasal voice or sometimes normal examination findings. Esophageal perforation. which is considered as a benign gist. This word to word taken from submission only. 2 centimeter in size, 3 mitosis, 550 hyperfield. See, benign, less than 2 centimeter, no more than 5 mitosis by 50 hyperfield. Page number 1233, submission 21st edition. If the same question is given and this answer is straightforward from submission. 20-year-old male with a raised intracranial pressure, vomiting, CT scan showing intraparenchymal hemorrhage in the brain. What is true statement? So, it is only intraparenchymal hemorrhage. You do not see as a space occupying lesion here. It is not given in the question like. So, the right answer for this question is continue medical treatment to reduce intracranial pressure. That is it. Once it organizes, in case of a chronic subdural hematoma, the organization of the blood, whichever has blood, it can get organized into a space occupying lesion. So, organized clot, that will take some time. If it develops, okay, or it gets absorbed by just a medical treatment, and that should be fine. Okay. So, you will do a external ventricular drain. If there you see a bleeding inside and getting accumulated, you want to evacuate it, whether it is in the ventricle or outside of the ventricle. Endoscopic clipping, if it is going to be a berry aneurysm, something like that. Lumbar puncture, and this role is limited, it is mostly diagnostic. So, what is very clearly said is, in patients who have less than 1 centimeter of clot from the cortical surface, the medical management remains a gold standard. However, includes moderate blood pressure control, normalizing the platelet and clotting functions, phenytoin and levetiracetam for seizures, prophylaxis and electrolyte management. Intubate the patient who cannot clearly follow the commands to prevent aspiration. Follow and document neurological examination. Very clearly said. So, first medical treatment, if it fails, then there is a bleed has to be evacuated, do an external ventricular drain or called ventriculostomy, if it is going to be the ventricle, or you do an external ventricular drain if the bleeding is into the ventricle. Understood? And in case there is a space occupying lesion is also there, if it develops, then you can put a burr hole and you can drain under image guidance. So, all those facilities are also available. Patient on carbimazole develops a sore throat. What is the next investigation? Because carbimazole, propylthiouracil, anti-thyroid drugs have similar, fixed side effects, recognizable side effects. So, you should go for WBC count because they are known for agranulocytosis. They can cause agranulocytosis. Understood? So, that is the reason why you should go for WBC count. So, it is very clearly said that anti-thyroid drug, use of anti-thyroid drug, yes, when the patient develops sore throat or fever, okay, patient should be monitored for possible complications, should always be warned to stop PTU or methimazole immediately and seek medical advice should they develop sore throat or fever. Treatment of agranulocytosis involves admission to the hospital and discontinuation of drug and broad spectrum antibiotic therapy.